two, one. Okay. Hello, judges. My name is Rihanna Srihari, and today I strongly affirm the resolution that physicians ought to prefer the biopsychosocial model of health over the biomedical model of health. We see that this is a value round and that the word ought in the resolution implies some kind of moral obligation. And we tell that in that way, you're going to be judging this round off of a value and a value criterion. The value that we propose in this debate round is equity and justice in health. And the value criterion or way of measuring that is through quality of life. So specifically, you're going to be looking at which team best improves the quality of life for people in order to access that value of justice and equity within the health space. On definitions in the resolution, we see that biopsychosocial model of health specifically refers to a model that systematically considers biological, psychological, and social factors and their complex interactions in producing illnesses. It often refers specifically to chronic illnesses, but can be used to target pretty much any kind of condition that someone is suffering under, and specifically be used to look at whether or not that condition is rooted in some kind of social factor that propels or perpetuates it. We've defined physicians to be health professionals or practitioners that are qualified to practice medicine. And we define biomedical medicine as a kind of reductionist way of looking at medical conditions that frames any disease as a deviation from the norm of measurable biological or somatic variables. Biomedical medicine specifically believes that the only effective treatment for pain is medical, so rooted in medicines for people to be taking. In that way, the burden of the affirmative in this round is specifically to prove that when these two things are in conflict, when physicians are having to choose between one or the other, they should always be prioritizing and preferring the biopsychosocial model of health above any other model of health, but specifically above the biomedical model of health. In other words, if they have a patient that they are trying to figure out how to treat, they should always be prioritizing using this BPS biopsychosocial model instead of just using the simple medical model that uses medicine as a way to solve any kind of illness. With that, let's move on to the first contention. It's going to just be that of better medical care. We see that biomedical care is specifically unable to explain the way that chronic pain persists after treatment. So, for example, when people who were in war experience phantom pains or feel like they still have a limb that is no longer there, this is an example of a condition that only biopsychosocial medical treatment can fix, because this isn't an issue of a tissue being there or of some kind of medicine being needed to treat it. It isn't an issue of needing an actual alteration of brain chemicals. It's just an issue of social and psychological factors implementing and harming a person by creating this kind of feeling of a phantom limb. This is just one example of where biomedical conditions can't really come in and help because they're unable to actually explain why chronic pain is still persistent even after treatment happens. We also see that in contrast, biopsychosocial medicine looks at patients' unique biological, psychological, social comorbidities, illnesses, beliefs, access to maybe some kind of depression or anxiety, financial concerns, and any other kinds of social factors that could affect the way that they are feeling their illnesses. In other words, while biomedical illness looks, or biomedical treatment looks at whether or not a patient is actually feeling pain and measures this through objective measures, the BPS model looks at whether or not this pain is rooted in other issues and also measures how frequently and how strongly the patient, I like the cat, the patient is feeling that pain. What that specifically is going to mean is that if a patient is feeling some kind of really heavy chronic illness, a biopsychosocial model is the only model that can actually look at that illness and specifically look to why the patient is feeling it, what social factors are making it worse, and how the patient is feeling it, not just what the illness is. This also means that it's a more holistic model of health that looks at whether or not families are feeling the same illness or same effect of illness as the patient is. If a family is looking at their parent that is facing a really severe chronic illness, that family might also be both contributing to the illness and taking on a burden of feeling as well. Yeah, I'll take it.
Why do we have objective procedures in science? For example, the scientific method.
Right. I mean, we tell you that objective procedures in science often help to kind of target illnesses and create really specific methods to solve them. But what we're saying to you, Judge, today is not that biomedical approaches are bad. We're saying that the preferred framework of the resolution means that we're looking at when the two are in conflict, when a patient is choosing between biomedical and biopsychosocial methods of treating themselves. The physician should always be choosing the biopsychosocial model because it's more holistic. Also to the fact that the BPS model includes biological factors, right? It includes objective measures of health because biomedicine is looking at objectively whether or not genes and genetics are contributing to feelings of illness and feelings of issues of health, right? The biopsychosocial model looks at that as well. It's more holistic. So on the impact level of better medical care, we see that what this specifically means is that people are able to access better treatment, which helps them live for longer. But we also see that quality of life is specifically impacted by having a physician that cares about your social and psychological impacts of your illness, as well as the actual physical impacts that the illness has on you. That means that patients are happier and get better quality of life, but also trust their physicians more to provide them with the right ways to measure that illness and the right ways to solve it. This is on net better for patients' health and also for physicians who feel like they're doing better at treating their patients. The next contention is that of equity. There's going to be 3 key points under this. The first is motherhood. We see that non-clinical barriers to health, i.e. barriers outside of the biological sphere, result in up to 50% of health outcomes, which means that specifically the psycho and social aspects of biopsychosocial health are very, very determinant of how much a patient is going to feel the impact of the treatment that they're facing or the condition that they're facing. On the motherhood point specifically, we see that mothers and specifically gender minorities are more likely to be overlooked in the healthcare system to the point where when they are facing some kind of pain, whether this be a postpartum issue or an issue before the birth, those parents are much more likely to face burdens of being overlooked in medicine, being told that their illness is not really mattering or told that their illness is being blown out of proportion. The biopsychosocial model prioritizes how the patient is feeling the illness, not just what the illness is. And it also analyzes the impacts of pervasive misogyny and its burden on people that are gender minorities or people that are having children and giving birth and facing the social alienation that might come along with that. This means that biopsychosocial effects of medicine are going to be important to preventing mothers and other gender minorities from slipping through the cracks when it comes to medical treatment. The next argument is that of race. We see that 42.4% of Black males and 44% of Black females have higher blood pressure. And this is a result of specifically social conditions where we see that racism actually has a pervasive impact on physical outcomes for people. Racism strongly is associated with health difficulties, and things like epigenetics also connect that, where people face the burden of being under pervasive racism and therefore feel these physical burdens and physical outcomes happening as well. That means that targeting racism is key, and only biopsychosocial medicine can solve for that because it isn't reductionist. It doesn't view medicine and medical treatment as being the same for white people and Black people and brown people. It views indigeneity as being a factor in whether or not healthcare works. It looks at the social conditions of people and whether or not the healthcare treatment is going to work in the social fabric that they're living in. The third argument under this contention is that of addiction. We see that right now. Obviously, genetics are a biological part of treating addiction, but that psycho and social conditions also matter a lot. And that looking at the problem, the predisposedness of addiction for the person, and also whether or not there are factors around them that socially perpetuate that addiction is really key to solving for addiction. And only biopsychosocial medicine can do that. For these reasons, it's a strong vote for the affirmation team.
Okay.
Sorry. There we go.
Hello. Okay. My name is Eloise Vidal-Gottesman. I use she, her pronouns. I will be the first speaker for the opposition. Is anyone not ready? Okay, perfect. I will begin my time. I stand on the firmest of opposition that physicians ought to prefer the biopsychosocial model of health over the biomedical model of health. Quickly to go over the burdens of the round. So the government must prove that the biosocial model should be preferred over the biomedical model. And the ought must prove that either the biomedical model should be preferred more or equally to the biosocial medical model. We on OP argue that this should be evaluated on a case-by-case basis, and there should not be an inherent preference over the biomedical model. We say that the biosocial model can be preferred equally to biomedical models, or the biomedical model can be preferred over. And then, Judge, as an observation, the two models here are always in conflict, meaning that a physician always has to choose between the two. So instead of always choosing between the biopsychosocial model, as the government argues, we say that it differs for every physician. Psychologists should maybe choose the biopsychosocial model, but EMTs who are dealing with people who are in pain or in actual problems that need to be addressed in the moment should not be analyzing someone's entire history of mental health when they need to sew up an injury. So EMTs should not be always prioritizing this biopsychosocial over biomedical, which I will get more into in our contention. So our first contention is lacks applicability. The biopsychosocial model of health has never been a scientific model or even a psychosocial coherent model. It was a slogan whose ultimate basis was eclecticism. So ideally, a scientific model has both specificity and predictive validity, and permits experimental verification or refutation of its various components. The biopsychosocial model lacks all of these factors. So what are the links here? Subpoint A. In science, we need a coherent model of applicability. When we use a model, we have to be able to apply it procedurally and reach the correct and same result every time. That is the point of ideas like the scientific method. The issue is that the biopsychosocial model is so subjective that it is impossible to apply coherently. This means that a patient receives 3 completely different diagnoses and recommendations for 3 completely different doctors. This presents a whole variety of issues, like if someone who has more money or of a higher class can reach a doctor that might be more trained in this, they're going to get far better care than someone who maybe cannot reach the same doctor or cannot go to as many different doctors to get different opinions. The subjectiveness of this model means that people are getting vastly different care, which is incredibly harmful. And then subpoint B, time constraints. Implementing the biopsychosocial model often requires additional time and resources, such as conducting more comprehensive assessments or involving multidisciplinary teams in the care process. We argue that most people do not have the money or time to spend on this process. This leads to less people actually getting care and more health problems. And further, it will take far longer. If someone can afford this, it'll take far longer for their problems to get diagnosed and for people to get the care they need. We see that this leads to people being in pain for longer, people not getting the health care they need longer, and their health problems getting worse. And then subpoint C, the biomedical model is tried and true. Almost every branch of Western medicine uses the biomedical model as the foundation for their scientific approach. There is a reason for this. It works and it can be applied universally. So what are the impacts of this? If doctors prioritize the biopsychosocial medical model always, it means that doctors are unable to apply a model in a scientific method quickly and efficiently, which makes patients receive less effective treatment or less treatment in general, which leads to more death, more health problems, more disparity between classes, and more ineffective treatments. Okay, our second contention is doctor bias is magnified. So the biopsychosocial model takes any doctor's bias and magnifies it tenfold. This leads to women, patients of color, or any type of person who a doctor could potentially have bias against getting far worse treatment. So what are our links here? Subpoint A, bias towards groups can lead to a doctor misdiagnosing or blaming a patient's life for their medical problems. This causes issues like people of color being disproportionately ignored or misdiagnosed when they have legitimate medical issues that are simply being blamed on their social surrounding or personality because of a doctor's bias. And then subpoint B, what does this look like in practice? So if I go to an ear doctor or to an ENT for an infection in my ear, I don't want this doctor asking me about my home life. I don't want this doctor analyzing the past 16 years of my life. I want them to give me antibiotics for my ear infection. The biopsychosocial model is inefficient, uncomfortable, and inaccurate for both patients and doctors the majority of the time. And then subpoint C, while the biopsychosocial medical model can be considered in medical situations, it is crucial that the patient's actual health problems and symptoms are prioritized. Otherwise, we get a subjective and harmful healthcare system where patients are essentially at the mercy of their doctor's preconceived biases about their lives, their race, their gender, whatever bias the doctor could have. So what are the impacts of this? There's an increase in misdiagnoses, especially for marginalized groups, higher rates of sickness and death for those groups and everyone, less people going to the doctor because of these long drawn out process, uncomfortable process, and not getting the actual help they need, which creates worse health for the general population, more death, worse healthcare. Okay,
Yeah.
let's move on to the government case. I'll take it if I have time. Actually, no, I'll take it now.
Do biomedical healthcare systems prevent racism against people?
We say that they do it better than always prioritizing the biopsychosocial medical model, because the biopsychosocial medical model essentially gives any doctor's bias this magnified way of treating patients. Okay, so their first contention is about better medical care. We say that the vast majority of medical treatment is not for stuff like chronic pain. While some chronic pain does exist and the biopsychosocial medical model can be considered in these situations, most people go to the doctor for other reasons and should not have their entire life analyzed by this doctor when they're trying to get antibiotics. And we say that psychology still applies in the biomedical model, but doctors are inherently practicing a different model. And then they talk about how the biomedical model measures things through an objective model, and we say that this is good because that is the only way to apply scientific reasoning. We need objective scientific reasoning for medical problems, or else there's just vastly different care for patients, which we argue is bad. And to move on to their second contention, they talk about how people are going to be more, people are going to be getting care because of issues like motherhood, race, and addiction. People are going to look at the whole lives of these patients. And we say that there will be even more misdiagnosis in Gov World because biases are magnified. And then they talk about the subpoint B is about race and how Black people have higher blood pressure. And we say, what does this actually mean? In the end, both sides give the patient medicine for high blood pressure, but one side does it faster. One side actually gives them the treatment, and one side, the government side, doesn't give a doctor the ability to say, well, you have all of these things surrounding your life, and maybe you should look at those before I give you the actual medication you need, which puts that patient in a worse position, doesn't give the patient the medicine they need, the treatment they need, and makes their health problems get worse because the doctor now has all this bias that can be magnified. And they argue that psycho and social conditions and predispositions need to be examined for issues like addiction. We argue that this may be true, but one, the biopsychosocial medical model can still be applied in the opposition world. We are not arguing it can never be applied. We are arguing that it should not always be applied over the biomedical model, which actually is objective and works. And then two, the biopsychosocial medical model can still lead to ineffective treatment. So cross-apply almost all of our arguments on the opposition. So for these reasons, I strongly urge an opposition ballot. Thank you.
So the order for this speech, I'm just going to go and respond or just give an overview and then resolve some of the conversation about what the burdens for each side are in this debate, and then go do the responses on affirmation case and then make a bunch of responses on the neg case. Cool. If everybody is ready, my time will start now. Hello, my name is Abby Wee, and I'm going to be the second speaker for the affirmation in today's round. Because Rihanna and I believe that physicians should not just focus on patients and reduce them to their diseases or illnesses, but view them as people who are subject to complexities around their race and social conditions in the way that they live, we are proud to affirm. So before I get into any of this line-by-line analysis, I just want to talk about this conversation about burdens. Now, my opponents present this framing that they have to be promoting the more or equal ideology of the relationship between biopsychosocial and biomedical modes of healthcare. And so right now we see that you can just extend my partner Rihanna's analysis about how these two are usually or should be viewed only when they are explicitly in conflict. And so my opponents, when they say that these two models are always in conflict, kind of misunderstand exactly what we're trying to argue here. What we're trying to prove is essentially that in cases where physicians have this opportunity to treat a longstanding issue such as chronic pain from a biomedical perspective, they should instead choose to use this biopsychosocial perspective. Again, of course, healthcare is by this case-by-case model. However, when we see generally, we see that it is better to prioritize this biopsychosocial model of healthcare. But Judge, even if you don't buy that the affirmation just really has to defend this when in conflict modality, we see that biopsychosocial healthcare is probably on net better to be applied in pretty much any situation, just because they provide better outcomes for especially people of color or other minorities. We see that the NIH finds that biopsychosocial healthcare is a critical method for race-aware and culturally aware healthcare, and generally has better healthcare outcomes in comparison to physicians who only use this biomedical healthcare. Now, they give you this example of how EMTs shouldn't be using this biopsychosocial method and it's only for psychiatrists. But Judge, they misunderstand what biopsychosocial healthcare is, and this is kind of the foundation of their case, right? We see that a biopsychosocial healthcare for EMTs would be EMTs recognizing that maybe somebody who they are trying to treat who is having a bad drug-induced psychosis, for example, is not yes, deserves acute care, and they will give them this acute care, but also recognizing that no, maybe using violent force on somebody who is having this negative experience is not a good idea. And so here we have this increased empathy. Biopsychosocial healthcare actually builds empathy in physicians and allows them to actually treat patients as patients and not just their illness, not just their psychosis in this case. So that being said, let's go to the responses on the first contention. Now, the only response to this contention is really one, this idea that chronic pain is not applicable and should just be given to psychiatrists. And also this idea that not all physicians use psychosocial healthcare and biomedical is better. Now I can respond to these in turn. We see that for the first example, we see that biopsychosocial medicine can be applied pretty much in any scenario. For example, let's say that a busy mother is in the ER because she sprained her ankle, for example. And so then in this case, a biomedical model would just tell her to like compress the ankle, get some bed rest, and essentially do like the standard, like, I don't know, like things that you do to treat like a sprained ankle, right? But a biopsychosocial like model will have the like physician ask, hi, are you able to actually take some time to rest and elevate your ankle, or do we have to find some more solutions that are compatible for your lifestyle? So then, Judge, it's really clear to see how yeah.
Where are the money and resources for this going to come from for these patients and the
Like
time?
the money and resources for a physician to ask a question to a patient that they're seeing in the ER? I mean, it's a 5-second question, right? I mean, it's like, hi, is this a feasible treatment option for you? Or do I have to like adjust the medicine that you're getting or adjust the compression type that I'm giving you? It's really that simple. It's not like this whole drawn out process where you go to therapy for like 3 weeks just to figure out how you like treat your ankle, right? It's this one question that allows physicians to really understand if their treatment is going to be effective for their patients and how to maximize those positive impacts. That's all it is. Don't let my opponents like make you like think that everybody's going to bear their entire life story every time they go to the ER. What we're actually seeing is more empathetic, more effective healthcare. Now, on this contention, the things that I want you to extend is this analysis that my partner Rihanna gives you about how biopsychosocial models of healthcare solves problems that biomedical healthcare fundamentally cannot, to the point where we see multiple studies that prove that chronic and unexplained pain outcomes through multidisciplinary biopsychosocial models of healthcare are much better than like typical care options. We see that this is probably a unique reason why biopsychosocial models of healthcare are uniquely key. So we see that the impacts of better treatment and quality of life, happier patients who are treated by more empathetic, more understanding physicians, is probably a net good thing. Extend like this value of quality of life framing, like which side is probably going to be better for quality of life, like a side like in the negations world where they're saying, okay, just the person is just their disease and just their illness and how can we just solve their illness, versus the affirmatives world, which is just looking at like how can we improve the outcomes of like this person, this like entire patient. Now let's move to the second contention about equity. The essential like this okay, the only response here really is like just this idea that like again, like, I don't know, like you get therapy before you get any sort of like treatment. But Judge, again, just classify the fact that this is not how biopsychosocial healthcare works, right? You treat like the like acute symptoms, like if you have like a sprained ankle, you treat that, but then you also figure out how to improve their situation long term. So in a case where you have high blood pressure, you would give them like lower breath. No, sorry, I don't have the time. I'll take it at the end of this contention. You would give them like the medication that they need to do it, but you would also sit down and talk to them. Hi, do you find areas where your blood, like, do you find situations in your life where your blood pressure is increasing, or how does this like higher blood pressure improve your life? Like that is the kind of thing that you're doing with biopsychosocial healthcare, and it's uniquely key. Also classify the fact that biopsychosocial healthcare is uniquely important in improving outcomes in terms of like gender minorities in healthcare, as well as just race-aware healthcare, as well as solving for addiction, something that biomedical health, like biomedical systems of health have failed at for like the past, like, I don't know, like number of decades. Okay. Next, let's move on to the negation contention. So there's a couple of like overview points. The first is that right now bias exists in the negation world and exists in the medical world to a point where it is like a uniquely key problem that biomedical like healthcare cannot solve. But secondly, we see that my opponent's emphasis on objectivity is so bad, because that is the kind of framing that makes it so that like women's pain is minimized. It's they are told that their pain doesn't matter on the basis of their gender, right? Because it's not like objectively measurable. Pain is not like this, like pain and like some experiences of disease are not necessarily objective, and they're mostly subjective. However, we also see that biopsychosocial like healthcare is not just like this like ignoring objectivity, right? It incorporates subjective experiences of pain. So with that being said, let's move on to the contention one about like application issues. The thing to understand is that biopsychosocial healthcare has been around for like, I think like the past 50 years, to the point where biopsychosocial healthcare is on the MCAT, the test that doctors take to like get into med school, but also like part of modern physician training, especially in the like realms of like chronic health. We see that there is a framework and procedure, like my opponents like claim that it doesn't exist, developed by George Engels in the 1990s for single physicians. So a single physician can do pretty much everything part of this BPS. Sorry, I really don't have time. I'll take it after. Secondly, we also see that this like idea of like not good enough because it's like not the Western model is probably like not like a great like argumentation, but also we see that it is good enough, and in Western models and in objective studies, it has proven to be more effective. Real quick on the second contention, we also just see that we have to like prioritize this understanding of how pain is based on like these social factors. And the second thing to understand is just that biopsychosocial like healthcare is like opt-in. Like if you don't want to like volunteer the details of your life to like improve your healthcare, then you don't need to. But at the end of the day, because biopsychosocial healthcare can just be as simple as asking a question and adapting someone's healthcare treatment based on that, we see that the only side that you can be voting for in today's round is the affirmation. Thank you.
Okay, cool. Hello, everyone. My name is Elliot. I'm the second speaker for the opposition in this round. Just a quick intro. I guess no preference on pronouns, for, POIs verbally, please. And I'm just going to go over some top of case stuff, talk about like framing, definitions, etc. And then just go over off case, gov case. So without further ado, my speech not to exceed 8 minutes. We'll begin now. So first, I want to talk about framing, and specifically on the framing that the two models here are always in conflict, meaning that a physician always has to choose between the two, right? The only response to this by the government is basically to say that, like, in cases where physicians have the ability to treat like, oh, chronic pain, or basically what they're saying is that when the BPS model, I'm saying BPS here for biopsychosocial, when the biopsychosocial model is better, then use it. A few reasons why this is wrong. First, this is like inherently true and basically doesn't lead to a constructive debate. The idea that you're saying, well, when this model is better, then you should use it, otherwise you should use another model, is not what the resolution states. The resolution states that physicians ought to prefer one model over the other, right? What even is a model of health? It's a way of kind of evaluating how you should treat a given patient, right? Treat a given illness. So the idea that you should say, well, for all of these ideas, we should, be preferring X, except for these when we should be preferring Y. The government is not upholding their burden, right? Physicians ought to prefer the biopsychosocial model of health over the biomedical model of health when they are in conflict. We argue that they are always in conflict. This is never rebutted other than to say, well, sometimes one is better than the other. Obviously, one is better than the other. On op, we're saying, yeah, you should probably evaluate that. Gov has to always apply the biopsychosocial model. Secondly, they say that and then we talk about EMTs, right? We say that like because Gov defines a physician as basically someone who practices medicine, EMTs would fall into this category, meaning that when an EMT is like, for example, if I break my leg, I don't want my EMT doing a deep psychological analysis of my family, the mitigating factors within my life, et cetera, and then making a subjective treatment based off of that. I want them to go, okay, this person has a broken leg. Let's start out with, this painkiller. This person has, for example, is overdosing. Let's start out with Narcan, as opposed to saying, well, this person comes from a privileged background, so I'm actually going to wait to give them Narcan. It just doesn't make sense, right? Science, and especially for people like EMTs who are working in high stress environments where you need a procedure, the biopsychosocial model is not the correct way to actually apply medical procedures. It leads to the patients basically being worse off because you don't have the correct thing being applied every time. And then finally, they say that like the biopsychosocial model is not ignoring objectivity. They just kind of talk about the world's factors, right? I think this is an incorrect characterization of both models, and here's why. Under the biomedical model, you simply look at objective research and then make decisions off of that research. So what is incredibly important about this is that if there's statistics that say women are 40% more likely to experience X symptom from Y product, the biomedical model looks at this and uses it to determine what basically diseases what treatments you're giving to a patient. So Gov trying to frame this as like the biomedical model is just this kind of size fits all thing is wrong because two reasons. First of all, that just doesn't make any sense. And second of all, the biomedical model is what is used in all Western medicine today. In the status quo, almost every single doctor in the US, I'm pretty sure all like doctors who are employed by the government, use the biomedical model. It is the standard. Meaning that, Judge, when you go to the doctor is obviously asking you questions. The doctor is obviously saying, hey, how will this affect you? That is applying the biomedical model just from an objective standpoint. All we are saying in opposition is that not every physician should be doing psychological analysis of the patient's health benefits. Again, and then so on our first contention, we say the biopsychosocial model of health lacks applicability. And what they basically argue is that frameworks and procedure exist. And we say, no, they cannot, because frameworks and procedure are inherently like in opposition to what the biopsychosocial model of health points out. The biopsychosocial model of health basically says for every single patient, you should be taking a subjective approach to how to treat that patient. This is inherently not in this. This doesn't align with any sort of framework or procedures because framework or procedures are inherently objective. We are arguing subjectivity versus objectivity. Ops says objectivity is better in most medicine. Secondly, we say, and then they don't actually respond to any of our analysis about like time constraints. All they say is like, well, you know, or they don't even have responses to it. So it flows across. Finally, on the tried and true, on the medical model being tried and true, they basically say it's been around for 50 years. People have been training it. So we ask this question. If it's been around for so long, why is the leading model of medicine in every branch of Western medicine still the biomedical model? This is never responded to by the government, and so flows across, right? We tell you that there's a good reason for the biomedical model being the leading model in all Western medicine. It's effective, it's objective, and it's able to be applied universally by all people, not just by someone with deep training in psychiatry, with deep training in philosophy or whatever, right? It's just not an objective model. And they never respond to this, so it flows across. Don't let them respond in their final speech. Okay, secondly, we talk about doctor bias. And they say basically say the biopsychosocial method takes any doctor bias and magnifies it tenfold. This is never responded to, other than basically saying that like, oh, well, we have to prioritize the social biases, right? Judge, you know what's inherently in opposition to prioritizing the social biases? Or you know what's a prerequisite to prioritizing social biases? The patient not dying. What we basically say is that the only way to prioritize, we should not be prioritizing the biopsychosocial method every single time because it leads to doctors basically saying, oh, well, I believe this thing is true about this marginalized group. Therefore, I'm not going to apply the science that has been proven for years and years on end. It just doesn't lead to a good model of health. This is the argument that we make, and it's never responded to by the government. They basically say like, oh, well, you know, the doctor's asking, it's like as simple as asking a question, right? This isn't true. Again, we give you analysis on how the biomedical model is used in Western medicine. It's used today. When you go to the doctor, you're using the biomedical model. Doctors obviously ask questions. And again, this analysis is not responded to. Now on GovCase. So on their first contention, they talk about better medical care. And what we basically say is like the vast majority of medical treatment is not, you know, this kind of does not need this deep psychological analysis. It's basically saying, hey doc, it hurts when my arm does this. And they go, okay, here's a way to treat when your arm does this, right? So that analysis, the idea that like the biopsychosocial model can be applied in any scenario is just not true, right? Like if a busy mom in an ER has a sprained ankle, we say there are no tangible benefits to the people basically going, okay, well, here's all of the like, you know, analysis. Like obviously, again, in the status quo, the idea behind the biopsychosocial model is not quote unquote asking questions, but it's like taking an entirely holistic approach to giving treatment. Doctors in the status quo, again, as I point out, use the biomedical model. You're obviously able to say, hey, is this treatment effective for you? That's not what we're arguing about. What we're arguing about is, should we be analyzing the psychological history of a patient? Should we be looking at stuff from a psychological approach as opposed to an objective medical approach? This analysis goes unresponded to. Don't let them respond in their final speech. Secondly, they say that like the biopsychosocial solves things that biomedical cannot. This is not what we're arguing. We're saying when in conflict, which is always, people should basically be using the model that best fits the situation. The biopsychosocial model obviously in psychology is more effective. This is not what we're arguing. We're saying because they're always in conflict, you have to choose one over the other. This is never responded to. Finally, on equity, we say therapy. I mean, like basically, our whole analysis here is that this takes a ton of time and money. This is never responded to. Basically, we say being able to even go to the doctor is a prerequisite to like receiving medical treatment in any fashion. Healthcare is already so expensive in the United States. It's not efficient to, you know, spend an hour longer at the doctor because they're asking all of these questions, because they're trying to analyze your psychological history. Secondly, we say like, what are the actual impacts of the second contention here? They have none. They never tell us why, for example, you know, analyzing race will lead to better treatment of blood pressure. All they say is that it's more efficient. For all of these reasons, urge a strong opt ballot. Thank you.
Okay. Eloise Gottesman, she, her, hers. You know the drill. Is anyone not ready? Okay, lovely. I will begin my time. I stand on the firmest of opposition that physicians ought to prefer the biopsychosocial model of health over the biomedical model of health. And then just two main voter issues, but first, an observation. The two models here are always in conflict, meaning that in Gov world, the physician always has to choose between the two. And we have given you warranting on why every physician should not be always choosing the biopsychosocial model of health over the biomedical model of health. For the examples like EMTs or ear doctors or skin doctors do not need to analyze my entire life history to give me antibiotics. And further, another observation, we can still use the biopsychosocial model in the opposition world, but we are simply arguing that it should not and is dangerous for it to always be prioritized. Okay, now to get into the two main voter issues of the round. First, applicability. In science, we need a coherent model of applicability. When we use a model, we have to apply it procedurally and reach the same results. Otherwise, people get far different care. And that is the point of having things like the scientific model, and BPS, the biopsychosocial model, is so subjective that it is impossible to apply coherently. The government never actually explains how this is going to be applied and how it is going to be applied well, how it is going to be applied objectively in a way where people are actually getting the care they need. And so this means that a patient will receive 3 completely different diagnoses from 3 completely different doctors. And we don't know which of those diagnoses is correct. And a patient that can't afford to go to all 3 doctors is simply going to have to roll a dice and hope they get the doctor that gives them the right diagnosis. So this increases disparity in healthcare, especially based on class. And they have never explained the BPS model more than saying, and I quote, that it'll be 1 5-second question when you get to the ER. In this case, that doesn't change anything. 1 5-second question happens in both worlds. And 2, this is not how the model is actually applied. They have not explained this. And then we have pointed out that this model is expensive, time-consuming, and difficult for both doctors and patients to apply. The government never responds to where these resources actually come from, where this time comes from. And if 3 different doctors see 3 different results, then people get far worse care when they can't afford to go to 3 different doctors. Further, we argue that the vast majority of doctors' visits are for things like antibiotics or sprained ankles. We don't need the biopsychosocial medical model for these. It takes longer, is more subjective, and less efficient, so far worse for patients. So just on benefits to all patients and equity for all patients, we outweigh on this. The vast majority of doctors' visits don't need this. Okay, next on bias. So bias towards groups can lead to a doctor misdiagnosing or blaming a patient's life for their medical problems, specifically with the biopsychosocial medical model. So this causes people of color or women to be disproportionately ignored or misdiagnosed when they have legitimate medical issues that are simply being blamed on their social surroundings, on like sexism, and when they just need painkiller for a sprained ankle. So any bias a doctor has is now magnified tenfold, and this is bad and leads to far worse care. The government never actually explained how this reduces bias or increases care. They simply say that it does. And the simple logic that you can go through, Judge, is that it increases bias. If a doctor is taking care of a patient, they have bias towards this patient, and they are analyzing the patient's life, this bias is going to lead to worse care. It is simple logic. And there are no checks on doctors in the government world because of the subjective applicability of the BPS model. Okay, finally on weighing. We say that far more doctors' visits are more efficient and effective if we use the biomedical model. We say that visiting doctors is a prerequisite to medical treatment, and this is never responded to. You need medical treatment for life, for having a healthy life, and this is increased quality of life. Further, they never respond to how the biopsychosocial medical model amplifies class differences and bias towards race and gender. And so under the weighing mechanism of equity, we win on this alone. And then finally, because they argue that quality of life is how we should be establishing equity, OP uniquely proves how the biomedical model of health leads to better treatment in the status quo. Gov impacts do not prove quality of life because they are entirely based on speculation and no explanation of how this is actually applied. The government proves how this is applied. So the government proves how it is applied badly. So for these reasons, I strongly urge a opposition ballot.
Awesome. Okay, judges, so the order for this speech, I'm going to start with an overview statement on the framework level, and then I'm going to move into some analysis of like exactly what the app is proposing, and then I'll cover the neg case and then the F case. Is everyone ready? Okay, my time will start in 3, 2, 1. Judge, at the end of the day, Abby and I have sufficiently proven to you that biopsychosocial medical care encompasses both biomedical approaches, right? Giving people treatments, giving people antibiotics, giving people the things that they need in order to survive, and psychological and social conditions that perpetuate and exacerbate those conditions. In other words, even if you believe that we need medicine, which we all agree with, even if you believe that we need quote unquote objective healthcare, which we tell you doesn't fully exist, and even if you believe that a patient that's in the ER or needs antibiotics should just get those antibiotics or get that ER treatment as soon as possible, you're still voting for the affirmation team because biopsychosocial medical care, right? That kind of mindset encompasses both the things that biomedical mindsets encompass, right? Looking at what medicine someone needs, what their physical condition is, and the way that their psychological and social conditions impact them. In other words, in the long run, the better medical care for any person to receive is biopsychosocial medical care because it means the physician has a mindset that considers how social and psychological circumstances will worsen their conditions over time. Giving a kid antibiotics is good, but if their social circumstances mean that it's harder for them to remember to take those antibiotics because they have some kind of ADHD issue or something along those lines, it's good for the doctor to know that, socially speaking, in order to treat them better, give them better antibiotics. In any case, even cases where you think that healthcare is objective, it's still important to have social and psychological conditions taken into account. It's important for a doctor to ask the patient who they are and how who they are affects the medicine that they take before the doctor just prescribes a random thing. On the framework level, if it's true that the two are always in conflict, which the other team says repeatedly, sure, we can agree with that. That means that what our burden is to tell you that generally biopsychosocial medicine should be preferred. Because the resolution asks us to make this overarching statement, that's a statement that we have to prove, not that like the two are always in conflict or anything along those lines. Our only burden and the way that you vote for us on this round is by believing that encompassing psychological and social conditions matters to giving people better health care. Even if you buy all of their analysis that biomedical things are important, to the point where we've sufficiently proven to you that generally social and psychological conditions always affect and exacerbate health issues, you have to be voting affirmative. But even if you don't believe that, biopsychosocial medicine encompasses biomedical practices. This is a practice of physicians changing their mindset from being only focused on physical issues, right? Biomedical things that can be solved just by genetic mutations or like medicines, to a mindset that also encompasses the way that social and psychological factors affect and exacerbate those conditions. Obviously, judges, under this resolution, it makes sense for physicians to shift their mindset from what it is right now, which is focused only on giving people medicine, to a better mindset that's focused on also looking at social and psychological issues. To be clear, BPS over BM does not mean that psychology or social,
Okay, so the argument that the only difference between the two models is shifting your mindset is new. And also the argument that like the biopsychosocial model completely encompasses the biomedical model is also new.
Okay, I mean, we explained in both my speech and Abby's speech that biomedical, like biopsychosocial includes both biology, which is like medicines, and also psychology and social conditions. That's pretty much been explained since the PMC, and that is kind of the first contention about holistic examination. And on the issue of mindset, Abby says in her speech that the MCAT is teaching this already, and that it's just a matter of physicians kind of changing the way that they think about things and their approach to medicine when she's responding to the point about the amount of money to be spent on this. So I think this is just an extension.
Okay, judges discretion.
Up to the judges. Cool. Okay, if everyone's good, I'm going to resume my time. Now, so the underview of this entire kind of framework overarching point is specifically that biopsychosocial encompasses biology, psychology, and sociology. When you're weighing these three things versus just biology, it's obvious what side you're voting for, judges, because even in a random situation with antibiotics, social and psychological conditions still matter. Okay, on the negative side, there's three key arguments they're going for. The first is that not every patient should be psychoanalyzed. Number one, extend Abby's unresponded to point that this is an opt-in situation. If someone's at the EMT and doesn't want to share their social and psychological conditions, they don't have to. That means that there isn't some invasion of privacy, and normal doctor-patient boundaries still exist even in psychosocial medicine. But next, we tell you that obviously no doctor is just going to not prescribe ear medicine, even if the person needs it to save their life because their social conditions don't allow it. Obviously, the way that biopsychosocial medicine works is by it listening to what the patient has to say about their own analysis of their life and then applying that to medicine. If it's not applicable, it's not applied, but that's still a practice of biopsychosocial medicine because that's still the doctor at least listening to the patient and trying to examine how their life conditions affect the way that they feel that illness. Next, they try and tell you that it's too hard to train people or not objective. First response to that, it's on the MCAT, as my partner Abby tells you. This goes conceded, so you can just cleanly extend this. It means that it's able to be taught on medical tests, right? but also that this model has existed for at least 50 years from Engel's procedure, which is pretty objective. But we're also going to tell you that medicine isn't objective. As my partner Abby tells you, bias exists in the world of the NEG as well. Doctors are biased all the time, but encompassing that and also looking at like actually writing down their biases instead of just assuming a patient's social life, actually listening to what the patient has to say, that probably decreases bias. So you're going to be voting for us on that. Talking about how it's too slow, but obviously if someone's dying or needs short-term help, they get it immediately under the biopsychosocial model because it encompasses biology, right? We see that this also includes long-term treatment, thinking about whether or not a mother has time to rest. If they don't, they prescribe a better treatment. Finally, on it being expensive, this is on a physician by physician practice, and it's just a shift of mindset. They're already being trained for this through the MCAT, so there's no issue with expense. So ultimately, the biggest voting issue in this round, the thing that you're voting on, is bias. In the world of the negation team, bias gets worse. We see that this is true for 3 reasons. Number 1, bias already exists in science and medicine, but right now it's shielded and hidden. In the world of biopsychosocial medicine, doctors have to ask their patients what their home life is like, what their life is like, how their identity affects their condition. This means that doctors can't just assume what a patient's home life is like, can't just assume that a patient is underprivileged or whatever. The patient has to tell the doctor that, so this probably decreases bias. It prevents a doctor from just thinking that they're objective, because it means that we're actually looking to the fact that all medicine is subjective, that doctors' biases will always show through. But in our world, where we're also analyzing these psychological and social conditions that harm a patient, bias gets better because doctors are forced to confront their biases and also listen to what a patient has to say. For all these reasons, it's going to be a clear vote for the affirmation team. Great round, you guys. Thank you so much.
Oh, sorry about that. Great round.